welcome to another episode of You Didn't Get the Memo Show. I'm your host, Gloria Bailey Ray. And as always, we have an exciting show today. Listen, my guest, first of all, she's just live. She's got more energy than an Energizer Bunny. So she's going to bring it. And we need you guys to tap in. So, again, welcome to the You Didn't Get the Memo Show. We're airing live on Facebook, YouTube, LinkedIn. I want to say hello and give a shout out to all of you who are international as well as nationally that are tuned in to watching the show. Now, some of you may say, what is You Didn't Get the Memo? Those of you who are what I call my lifers, you know what it is. But You Didn't Get the Memo Show is about providing you, the viewer, with relevant, factual, mainstream information to help you be informed and to make informed decisions, y'all. That's literally what it's about. Now, You Didn't Get the Memo Show is also an interactive show. And what I mean by that, if you have questions or comments for my guest or just in general, you can place them in the comment section and we'll do our very best to respond to you, all right? So, let me just tell you, my guest today is Dr. Kasandra White. She's an OBGYN, and I'm abbreviating that, y'all, for those who say, what's that? Obstetrician and a gynecologist. And we're going to be talking today and tapping in about some information that I think is critical for so many of you to know. So let me just share something with you. Check this out. Are you aware that Black women are more than 3 times more likely to die in pregnancy and postpartum than white women? That's something for you guys to just kind of take in. How about this statistic? Black women are 5 times more likely to die from pregnancy related cardiomyopathy, blood pressure disorders than white women. And additionally, we're talking preeclampsia. Eclampsia is also the leading cause of maternal death among Black women. Why do I share these statistics with you? It's for you to understand what a pregnant mom can go through and what her risks are. This is why I ask you men to tap in. And by the way, slow your roll. We're not going to just talk about pregnancy. So before you click out of the stream, let's tune in and turn up that bell tone hearing aid so that you can get some information. I want to thank my guest, Dr. Kasandra. Thank you so much for tuning in and joining me. It's a pleasure to have you on the show. Awesome. Welcome.
Thank you so much. I appreciate that intro and for really going through and explaining and sharing some of those true statistics that exist for us as Black women in medicine and healthcare. So, but I appreciate you, Miss Gloria. Always a great time to have great conversation and discussion.
Absolutely. Yes. Yeah. And I've been looking forward to this. And the nice thing is I've had some, males reach out and say, hey, look, I want to tune in. I want to listen to this. So let's just jump right in and let's get started with, first of all, let's start with your backstory. Tell the viewers a little bit about where you grew up. How did you even get into medicine? And then, of course, you specialize. So let's talk a little bit about what Dr. White does, and fill our viewers in, please.
Thank you. Yeah. So much of my background is my motivation for what I do and why I serve the people in my community. I'm that little girl. I'm that little girl that born and raised in Oakland, born to a single teenage mother who had grandparents around to also fill in gaps that existed. I'm that little girl whose father was in prison at the age of 2. I'm also that little girl who started to take note of certain aspects of her community and realize that even though I didn't know what was out there in the world, I knew that there was something better for me. I also was that little girl that my grandfather used to always tell me there's no such word as can't. So that started to really dig deep and ingrain into my mind that, you know what, I can do anything that I put my mind to. So I ended up becoming that little girl that sought education as the way to really control or have some sense of control over my future and my life. Though I didn't have control of what was happening around me, I did have control of my education. I also was that little girl that was raised by her community. I had an aunt and uncle that lived down the street, and if I didn't walk past by 3:30 in the afternoon, they were out looking for me. If the neighbors saw me getting in trouble, they made sure that they let my mom know as soon as she got home from work. I was that little girl that saw a cousin graduate from college and realized, you know what, I'm going to go to college too. I'm also that little girl who had a best friend that had 3 kids in high school. That little girl who had a chance to see her sister born and decided at that moment when I was 16 that I would become an OBGYN. I'm also that little girl who, once finally getting to college, didn't listen to her counselors when they told her that she would not be good in medicine or consider doing other things. So I didn't listen, and I graduated college and became pre-med and decided to take that route. I also, on a personal level, was that little girl that took care of her grandmother who was sick and noticed some of the inequities that existed in the quality of care that existed while she was dealing with her own health issues. And once she passed away, decided to go and venture the world, lived in South Africa for a short period of time and came back and decided to pursue medicine. And then eventually became that little girl that came back to her community in Oakland, where I am now, and continue to serve my people. And I realized that, and it still catches me off guard, that I'm the first doctor in the family, and I also represent less than 1% of Black women surgeons that are here in the United States. So I'm that little girl.
Yeah. Oh my gosh. What I mean, just listening to you talk about, I love the way how you encapsulated, I'm that little girl. So for
Yes.
those viewers who have daughters and children in general, but especially, being told what you can't do and being steered away from something that in your heart of hearts that's out there. And kudos to you. You said, look, I'm going to get mine. And that's the attitude. And that's how we need to be talking to our youth and our young adult. If they say, I want to do this, for some that are younger, that career choice could change daily, weekly. But whatever it is, you want to give them the hope and the belief that they can accomplish and achieve that. So, and grandparents, look, did your grandpa tell you, you can do anything? And that's the important thing. So, you talked about, wow, a number of things. A best friend that had 3 children, before she graduated high school. So, when we talk about your role as an OBGYN, what types of patients would you say that you work with? Let's start with that because we're going to get more into patient types. But what would you say generally overall, the types of patients that you work with?
Yeah, I mean, it can vary. It's I work with young adolescent girls that are, looking to discover their body, talk about what their menstrual period is, to all the way to women past the age of 65 who, are coming in for their routine exam. They're, experiencing menopausal symptoms. I mean, it absolutely can range amongst many, many women throughout their reproductive cycle. I see women who are obstetrical patients, that are prenatal patients, pregnant, and then also women who aren't pregnant.
Right.
Um,
So that's good. And I'm glad to hear that. So for the ladies who you think is 60, 65, look, the playpen may be closed, but you still need to make sure that you're seeing your gynecologist and following up with really good health care. And men in general, you should want to make sure, hey, have you had your GYN appointment? Because there are so many things that can be caught early on, and it shouldn't even go down to, oh, this is life or death when it could have been treated. So thank you for saying that. But let's talk about not only patient type. Let's discuss, first of all, let's define, because I opened up with all of these statistics. But when we talk about a high acuity patient, a lot of times I know people in the medical field may know, but I do also think that family members need to understand if the doctor says, well, your wife, your woman, your boo, your daughter is a high acuity patient. What does that mean in the grand scope of things?
mm, mm, Great question. So I think of high acuity or acuity in two different realms. One, in the sense of their actual medical condition. Do they have certain what we say is comorbidities? Do they have medical conditions that can play a part in their current symptoms or their presentation? So, do they have hypertension? Do they have cardiac or heart disease? Have they had a history of cancer in the past? Do they have some sort of rheumatoid arthritis or lupus or some other medical condition that may come into play that you have to consider what the best route is to treat? The other, when we start thinking also acuity, I tend to think about it in terms of what are things that are contributing to the care model for this patient. Do we need to bring other resources involved in their care? Do we need to contact a psychiatrist? Do we need to contact and bring in a social worker? Do we need to bring in other specialists involved? And so that's kind of how I look at acuity, particularly in the healthcare setting.
Mm-hmm.
And it requires a lot of coordination a lot of times. So, when you're wanting that quick answer, and sometimes you can't always get that quick answer.
Yeah, absolutely. And you just kind of, your answer really just it just bled into the next question when we talk about at risk, because one of the things that I really want to get into, it's not just this high acuity, but when we talk about at risk, you can have a pregnant patient who has a mental illness, and that's considered probably a much greater at risk patient population as opposed to someone who does not have that. Would that be a true assessment?
Yeah, you like to not label someone as
Right.
at risk. I think there's an important piece to recognizing a patient's community and what resources they have and don't have, and how that may actually contribute to their risk factors for complications. Is it that their social construct? Is it that their ability to obtain transportation difficult to get to their appointments? Or do they work a full-time job where they're not able to take off work? Or, as opposed to losing pay, or deciding, do I keep the lights on versus paying a copay for this expensive medication? A lot of these constructs are deeply rooted into so much of our healthcare and what we see in terms of the acuity of our patients and how they contribute to the complications we may see. So I never, I the terms of having a non-compliant patient don't exist to me, and that's because there's always a reason. And
Right.
sometimes, we take that moment, though the system is very quick and fast paced. You may see your doctor 10 minutes in these clinic visits, but really sometimes it is a few minutes just to listen and kind of get a sense of what patients are experiencing in their life. And you can actually pick up why things may, why they haven't been at their appointment or why they haven't picked up the medicine, and kind of figure out ways and be creative.
Right, right. And what an excellent point and way to speak to that, because you are so right. The challenges that a lot of the BIPOC women in the communities are faced with. Do I go to work, or, so that I can get paycheck, or not get docked for this? And there's so many things. I know that we could get off on a whole nother tangent of how the healthcare system needs to actually work with the patient. But at the same time, you just said something that was really important, is taking the time to listen. And a lot of times I know that even physicians are running and they're trying to see and get through. And I think a lot of times patients don't realize that there's only so much time that you can spend with them. So I do want to say, and I do this myself, when I know that I have to see one of my clinicians, I make sure that I have a list of questions that are written out, so that when we go in, I can get those answered rather than bombarding them. Of course, now everything is on email. So you send them email and they got like 1,000 emails sitting there, and you want to know why they hadn't gotten back to you. So I'm really happy to hear that you actually take the time, but just having a quick update on what's happening and why, and how we can facilitate them getting what it is that they need in order to ensure that they remain healthy. And I appreciate you saying that.
Yeah, I appreciate you even sharing, some of the things that you do in terms of just making a list beforehand. Bring a family member with you. Sometimes so much information is coming out that by the time you get home, you may not remember a lot of it. So even having a family member, if that's possible, given the circumstances with COVID that exist, and
Yeah.
can't really have visitors now.
Absolutely.
Yeah, but also, I'm one of those physicians that I'm okay if you Google and look up, symptoms. Don't panic, but it may actually be able to help you formulate questions that are relevant to what you're experiencing, and don't be shy from the medical terminology. I always tell my family members, if I'm not available, these are just the questions that you ask. Just ask, why is this happening? What do I do about it? How do I make sure I'm okay? When do I come back? Very just simple, easy, directed questions that can really provide you the information that you need. Because
Yeah.
as I mentioned, I'm less than 1% of all the active physicians that exist here in the United States, and
Mm.
only I want to say 5% of the physicians make up Black physicians here in the United States. So if you think about women, it's only 2.7. So more than likely, you're always going to end up seeing someone that doesn't look like you, that may not be from your background. And so be very forward with your questions. As I mentioned, very generic questions that can really get a lot of information.
Oh my gosh, such great advice. Listen, we're going to take a quick break. And when we come back, though, Dr. White, let's delve into talking about at what age should parents arrange for their daughters to have a pap smear. Let's talk about what that is, because this is really key information. So, you guys don't go anywhere. You're tuned in to You Didn't Get the Memo show with my awesome guest, Dr. Kasandra White. We'll be right back, you guys.
Because of you, I feel not alone in this world. And you let me know that it only takes one person to make you feel wanted.
There's so many rewards in life. You coming into our home was one of the greatest rewards we could have ever had.
All right, you guys, if you're just tuning in, you are listening to the You Didn't Get the Memo show with my awesome guest, Dr. Kasandra White. And look, we're jumping into some stuff today. We're delving into some stuff. Before we went to break, one of the questions that I posed is, let's talk about what a pap smear is, and at what age should parents be looking at arranging for their daughters to get one? And probably somebody saying, well, why just the girls get it? So I'm going to kick that to you. And let's talk about that for a moment, please.
Yes, pap smears are really important. Every year, January is the month of cervical cancer awareness month. And so as we've now into February, but every day for us as OBGYNs is cervical cancer awareness. And we encourage young girls, particularly starting at the age of 21, all women at the age of 21 to start having pap smears completed. Pap smears have been shown to reduce the chances of cervical cancer as long as they are continued to be done. And for follow-up, right now the current guidelines are either between every 3 years or every 5 years. Those are just guidelines. So that means for someone that may be considered in a high risk category or have also had a history of a previous abnormal pap smear, that follow-up should be a lot sooner, at least every year or 6 months, depending on the actual indication. One thing that's really important, and some things that we encourage patients, so I get a lot of women that have daughters and they ask questions. So, is there something that we can do before they start getting pap smears? And that goes into discussions about the HPV vaccine. HPV is a virus known to cause most up to 90 to 95% of cervical cancers. And so HPV is also at times, depending on the age, it's tested and can be detected by a pap smear. So for young girls starting at the age of 9, they are candidates for receiving what's called the HPV vaccine. And the HPV vaccine has been shown to ideally reduce the infection that causes cervical tissue abnormalities or making the tissues abnormal that eventually can lead to cervical cancer. But even anyone that has had the HPV vaccine should still always get a pap smear and go see their GYN doctor.
Yeah. Dr. White, we have a question from one of the viewers, and they wanted to know, I'll put it up here to piggyback on your question, when do you no longer need a pap smear? Great question.
Great question. Now, the age that they said no longer needing a pap smear is the age of 65. Now, that does not mean that you subsequently can't have a pap smear after the age of 65. Now, so though doing the pap smear involves what we say a vaginal exam, even if you're after the age of 65 and no longer getting pap smears, still would encourage you go in for your routine GYN exam to still possibly address any kind of issues you may be experiencing, have a breast exam, sometimes also still have a pelvic exam where we're able to still take a look. Now, there is still a certain set of individuals after the age of 65 that should still continue to have pap smears. And those tend to be women that have had a history of abnormal pap smears or certain procedures. And there's very specific findings for that. If a woman has had a hysterectomy but still has their cervix, always also remember that. So any of the women that are watching this and who have had a hysterectomy, if you still have your cervix, you should still be getting pap smears up until the age of 65. And if beyond 65, only if you have certain risk factors associated.
Okay.
Great question.
Yeah, absolutely. You guys keep it coming. On that note, you talked about the HPV virus and the vaccine, but listen, we know, and I know you see it in your practice, that young girls are having their menses earlier and earlier, right? So, question, at what age should a female be started on birth control? Because parents are freaked out about that, and and I have to tell you, I still cringe when I hear that 11 or 12-year-old had a baby, and I'm thinking, what? But let's talk about it. This is what this forum is all about. Mm-hmm. So the question that's on the table is, at what age should a female be started on birth control, especially if she started early with her menses.
With her menses.
Period.
Her period. Yes. No. Oh, great question. Also, who are you coming with these questions, Ms. Gloria?
Okay.
So birth control, though we hear it as birth control, it's used also for other reasons. And usually for a young girl who is seeing their pediatrician, if they've started their menses and let's say that they start developing acne or they have very painful periods, certain birth control pills or birth control can be used to help with those symptoms. I think what tends to get parents cringe is because you think, okay, birth control, that's going to give them a door to having sex. Well, yeah, there are protective mechanisms when using birth control, obviously, to prevent pregnancy. But they can be used for other indications as well. And that's the important piece of it. And then subsequently with different birth control types, just depends on a patient's lifestyle and what's convenient for them, and also making sure that they don't have any certain contraindications to it, particularly if they've had a family history of stroke, or family history of stroke in an early age, or family history of blood clot disorders. Then certain estrogen component hormones should not be used in birth control for those patients.
Yeah, absolutely. Thank you for addressing that, because that's the one thing parents say, oh my gosh, you're going to start my look. And of course, they're my baby, even though she's 12, 13, fully developed, but you want to start them on birth control. And this is where we got to have that conversation too. We got to talk to them about sex. And it's it's not kind of like the back in the day when I was coming up, the birds and bees, keep your dress down, your panties up, and you're not going to get pregnant, because we all know that doesn't really work either. So the real deal is to make sure. And it really sounds like listening to you, I'm like, okay, Dr. White, you're on point with all of that for sure.
Hey, I mean, and a lot of it, Miss Gloria, came from, my experience, in high school, and my best friend who I grew up with from the age of 3 until we, finished high school, and had 3 kids at that time, freshman, sophomore, and senior year. And, for my mom, she
Did she let you hang around with her?
Well, she did, but I think she also trusted in me and knew that, I was focused on, I got to get to college. I got to become a doctor. Well, actually, I didn't know at that time. And my mother was pregnant with my sister when I was 15 and a half, 16. And what my mom ended up doing, what she thought was a good form of birth control, was for me to go to all her prenatal visits. And she took me out of school, which was really important for me. And so that actually, it inconvenienced me, because I was like, wow, you're taking me out of school. But she wanted me to experience what it was like going to these visits, and then subsequently was there for the 26 hours she was in labor, wiping the toilet after she used it. And next thing you know, seeing my sister born. And that's when I decided, okay, I want to be an OBGYN. But it also was for her showing me that, okay, like, this is some serious stuff, this is life-changing.
Right. It's not a cakewalk. Right. And so that definitely makes a huge difference. So we're going to take a quick break, because I want to get into us talking about STDs.
Okay. Yes.
Sexually transmitted diseases, you guys. We're going to talk about it. It's real, and we know that it's happening right now. So you guys don't go anywhere. I am here with my awesome guest, Dr. Kasandra White, and we're going to come back. We want to help inform you guys and educate you, and make sure that men stay tapped in, that you are really all in with your woman, with your female, whether it's your daughter, your wife, your mom, your girlfriend, your sister, whatever it is, because men need to know this information too. It's not just a one-way street. So don't go anywhere, guys. We'll be right back, okay?
Stem is precise, no margin for error.
Dare to forget that. Dare to have fun with it. Get weird with it. Dare to load their minds. Dare to explore. Dare to STEM. Learn more at She Can STEM.
All right, guys, I want to thank you so much for tuning in to You Didn't Get the Memo, and thank you for your questions. Good questions. We're having a great conversation here with my guest, Dr. Kasandra White, who is an OBGYN physician here in the Bay Area. And before we went to break, one of the questions that I posed to her was, let's jump in and let's just talk about STDs, or sexually transmitted diseases. What are they? What are the symptoms, and what do you see most in your practice? And I'm going to the real stuff, the syphilis, the gonorrhea. So let's just start with talking about it, because I know that it still exists. They haven't eradicated that. So let's start with what are sexually transmitted diseases for some, especially for some of our youth and young adults who are not quite sure what that is when somebody says, I have an STD. It's pretty serious.
Yeah, pretty serious, and can potentially have some life-changing consequences. So different types of STD, which are either viral or bacterial. You can't see them. Sometimes they can be very asymptomatic, meaning you may not have any symptoms, or you could be symptomatic where you have pelvic pain or abnormal discharge or burning with urination. May even have just a little sore, one little sore that's not painful, or that has no pain to it. And you're like, oh, maybe it's just the ingrown hair. And not to freak anyone out, but the symptoms can vary. And so when we think about different types of STDs, there's syphilis, HIV, hepatitis, gonorrhea, chlamydia, trichomonas, herpes. And those typically, and I will honestly say in a day-to-day in clinic, I can potentially see either one of those. And it's interesting that you brought that up, because I feel like most of the times when I talk about syphilis, I'm seeing probably at least one patient a week that either pregnant or not pregnant with a diagnosis of syphilis, new or a previous history of syphilis. So it's out there. When we talk about birth control, the other part of that are condoms. Condoms are the only source of which can be preventable for STDs. So taking a birth control pill, using an IUD, getting a depot shot, those don't prevent STDs. So either abstinence or using condoms every time. And when I say long-term consequences, some patients who have had a history of some sort of STD, like gonorrhea, chlamydia, we think about their fertility status. It can cause sometimes scar tissue of the fallopian tubes, which can make it difficult to become pregnant. If in pregnancy, if we have a patient that has syphilis or have known syphilis, it's important that we're checking their blood antibodies to make sure what we call titers are not so high where the infection can potentially reach the baby and then subsequently have consequences. And the same thing with HIV, and also we think about like herpes. Women that have a herpes outbreak later in their pregnancy actually commits them to possibly having a C-section. So, and you don't want to deliver vaginally late in the third trimester, because subsequently that can make the babies really, really sick. Yeah. So there could be a huge sequelae, a consequence
right.
that can exist with contracting a STD.
Yeah, absolutely. And you covered that gamut, but I was glad to hear you really encapsulate talking about syphilis and gonorrhea. That is real. And also, I just think back to the day of when we talk about, remember, I don't know if it's still considered that, you give a diagnosis of PID, pelvic inflammatory disease, right? Mm-hmm. And talk about the symptoms. And a lot of times these girls, we want you females to not ignore, if you feel a little funny, because your body better than anybody else. And if it feels a little funny, a little itchy, and like you said, I just think it's a little bump. It's not an ingrown hair. You need to go get that checked out.
Mm-hmm.
Blood.
Yeah. And sometimes that means not only you need to be treated, but also your partner needs to be treated.
Right.
And so that's where, bringing the men into the conversation to this as well, is that, it's important also that if their partner is diagnosed with gonorrhea, chlamydia, herpes in some form or fashion, like, you both need to be treated.
Right. And if you don't treat them, that's the crazy thing. You're just going to get reinfected if you continue to have, intercourse with that person. Mm-hmm. And the sad part about it is how these things spread, right? Yeah. You didn't treat, you knew what you had, but you're now, and I'm speaking from, it being one of those women that had girlfriends that are, I'm not going to give him the pill. And so he goes and sleeps with someone else. And the list, it just grows and grows and grows. So it's really important. Is what Dr. White is saying,
Mhm.
the need to treat and to be
Mhm.
treated. Right.
Yeah, and I mean, think about, if you know that you're sexually active, not using a condom, you're at risk, and
Mhm.
then make the time to maybe every 6 months or talk to your provider and find out when it's best to get routine labs,
Mhm.
STD labs on a regular basis. When women go in for their pap smears, you can always request for a STD screen at that time. Also, that's always a great time to do that. But I think about, if you don't know, then you can't address it. And when I think about syphilis has its different stages. So
Yeah.
though it may
Come
start off as
on.
like a painless sore, but then it subsequently can develop into brain infection and deadly consequences, and in those stages. So um, so important.
Yeah.
So
Well,
important.
we have a question from one of the viewers, and they want to know, why is it that adults shy away from having these types of conversations with their children?
Hmm. I will honestly say, I feel like growing up, we always had nicknames for it.
Uh-huh.
We still really didn't understand, that there was an inside, an outside, and the physiology of it. And I still think for possibly a lot of parents, it, there's still some lack of actually knowing exactly how to explain it, in the sense of, so I get a lot of patients that come in that have young adolescent girls, and they're asking me, Dr. White, how do I talk to them about it? And a lot of times I end up bringing out the actual anatomy model, so I can show them what the uterus and the ovaries and the tubes and the vagina, and just go over this physiology lesson and anatomy lesson that exists. The other is, it's, yeah, it's one of those where I think you think, am I encouraging some sort of behavior or not? Or, and I think that's where some of the apprehension may be.
Mhm.
But I think really establishing early on those conversations, talk about, are there friends that that are engaging in certain behavior, and really building on those relationships to have a really open relationship and honest discussion, because kids are going to find out.
Right.
They're gonna find out, but you don't want them to find out from the wrong people. Let it at least be you.
Yeah, absolutely. And I'll just tag on to that. I just think back to my childhood growing up. It was not something that, when you look generations back, they didn't talk about, like, where did babies come from? The stork brought them. I mean,
Mm-hmm.
but your mom's belly is still getting bigger and bigger. And so it's those things, and you're absolutely right.
Mm-hmm.
We've got to have those conversations, you guys. But within the context of that, it's
Mm-hmm.
about building trust too.
Yeah.
Your child needs to be able to trust you to come to you with a question, and you not freak out like, why you asking me that? Or, what you doing? How, before you start, take a moment and allow them to ask those questions, because who would you rather them get it from, like you
Mm-hmm.
said? And we don't
Mm-hmm.
know what can happen if you're just all on the internet all the time. So,
Right. Or on Instagram and Facebook. Nothing wrong with them, but you just want to make sure the information's coming from home and from a
absolutely.
good place. I also think about something that's important too is our family history.
Mm,
And making sure that we're having the discussions about why grandma passed away from cancer, and why did she have her breast removed, we never really found out, and really talking about family history, because it's possible that patient that comes into my clinic is having breast concerns, and she's
mm,
in her 30s and finds out, whoa, you've had a family history of ovarian cancer, or you had a father that had breast cancer, that puts her at a risk of getting breast cancer. So those things that those are the conversations also that we should be having
Right,
as
right.
well as a family.
Yeah, family history stuff. I don't know what that secretiveness is about, but it needs to happen and take place. So, Dr. White, let me, transition into this. Let's talk about ovarian cysts. Why do they develop? What brings that on, and what is an ovarian cyst?
Yeah, and ovarian cysts are really problems. They're problematic for a lot of women, and particularly women who are still menstruating, meaning they're premenopausal. They haven't stopped what we say ovulating or having a period. And so what happens is that within both ovaries, there's small, what we call small follicles, and those follicles release an egg with ovulation at each month. And ideally, with a woman having regular periods, that ovulation is pretty much like clockwork. Sometimes what can happen is those cysts can kind of seal off and actually develop and grow into a fluid-filled cyst. Now, some cysts, they are just what we call physiologic, normal part of a woman that has a regular cycle. Sometimes they stay the same in size. Sometimes they grow bigger and can cause pain or even twist the ovary. Sometimes they just end up just shrinking back down, or sometimes what we call they can rupture and really cause a lot of pain for women. There are different types of cysts. Some cysts have very clear fluid on the inside. Some cysts have blood-filled, like a contrast to it. And then other cysts can actually be a little bit more solid, where they can possibly have certain characteristics that most likely won't go away and may have to possibly be surgically removed. On the flip side, we also think about women who are postmenopausal, and we would expect that they may not be developing these cysts because they're no longer ovulating or releasing that egg from the follicle. And so when we have a postmenopausal woman and who has a cyst that we may see, or they present with pain in their pelvis and we get an ultrasound and we see a cyst, we need to pay attention and make sure that that cyst does not have concerning characteristics for possible ovarian cancer. We look at the size, notice whether or not there's any kind of increased blood flow within the cyst. We make sure there's any kind of solid components to it and other findings that may be significant in the imaging itself. Mm-hmm. And typically, the problem with particularly ovarian cancer is there's no screenings that exist. We know there's pap smear screening. We know there's breast cancer screening with mammogram, but for ovarian cancer, there isn't
Right.
There ain't
no. That's what I was just
there
saying.
ain't no screening mechanisms for ovarian cancer. So it's really making sure that if there is a cyst found by an ultrasound, there is a developed plan for following up on it. Mm. Right? Don't leave it out there. Just make sure that there's some follow-up. And not all cysts require surgery. You have to outweigh the risk and benefits of doing surgery, right? Because there are risks involved in doing that. Yeah. But make sure that if there is a cyst found on an ultrasound, make sure that it gets followed up with another repeat ultrasound.
So, Dr. White, just real quick, a Reader's Digest version, though. A cyst sometimes can be extremely painful. And that's what I asked that so that men would understand that when, a female says, I have a cyst, it's painful to walk, painful to move. When it ruptures, lots of pain. So that's a whole nother realm of when you're dealing with and find out that, your significant other or your daughter or mom or sister, whoever, they have a cyst. No, they're just not feigning pain. It's painful.
Painful. And then, and even with menses and period, that going through that, those symptoms that we experience.
I know. All right, we have another question from a viewer, and the question is, what is the next step for a woman with a confirmed BRCA2 gene? You probably have to explain what that is to our viewers, but for this particular person, great question. Thank you for asking.
Yeah, thank you. So some clinic locations offer some really easy, non-invasive ways of testing for what we call genetic mutations. Looking at certain genes that can predispose women to either certain cancers like breast cancer, colon cancer, ovarian cancer, endometrial cancer, or uterine cancer. And so depends on how you were tested. But once identified, then ideally, and what the plan should be is you're referred to a genetic counselor to look further into the family history, assess your risk factor, and then subsequently make recommendations on whether or not it would be beneficial to proceed with some sort of risk-reducing surgery. And that will all depend on what's assessed with the genetic counselor. So once identified of having particularly a BRCA gene mutation, that's when continued follow-up is necessary with the genetic counselor.
Right. Thank you for that. Question.
Yes, thank you.
A number of young women, school-age girls, that think, and I just remember reading an article about this, that think that having oral sex still allows them to be a virgin. What would you say is the potential effect of this type of thinking?
Well, I guess looking at the definition, is it, there's oral sex, anal sex, vaginal sex, or intercourse. What I want young girls to think about if they are engaging in oral sex, that kind of goes into our previous conversation about STDs, that you still can contract STDs through the mouth. That can affect areas back in what we call the nasal pharynx. And also, catch diseases like gonorrhea, chlamydia of the mouth, HPV of the throat, syphilis, herpes, if there's some sort of lesion. So anytime that there is tissue to tissue, or what we say mucus to mucus contact, those are some of the risks that can be involved, even engaged in oral sex. Though you can't get pregnant, but do know that there are possible chances of acquiring an STD.
Yeah, and that's real. That's something, when it's in the mouth, on the face, you can't hide that. That's a whole other thing. So we're going to take a really quick break. When we come back, Dr. White, I have two questions. It's twofold. I'd like to talk about the work that you're involved in to improve patient safety outcomes for the indigenous population of women. But at the same time, in your opinion, what's lacking in the healthcare system to allow for ongoing care or continuity of care for patients? So I said a mouthful right there, but I'll repeat it when we come back.
Okay.
But guys, thank you so much for your questions. Thank you for hanging in here with us. You are watching the You Didn't Get the Memo show with my awesome guest, Dr. Kasandra White. We'll be right back, you guys.
Thank you for watching the You Didn't Get the Memo show with your inspirational host, Gloria Bailey Ray. It's your contributions that make this happen. To become a sponsor, send an email to youdidn'tgetthememo@gmail. That's the letter U, didn't get the memo. If you're not in a space to be a sponsor, but you like what you hear, we simply ask that you support what you like by making a contribution to the show. There are 3 ways to make an online donation. Visit paypal.me/Gloria Bailey Ray or Cash App or Venmo, Gloria Bailey Ray. Give what you can. Your support is appreciated.
All right, guys, I hope that you have so far enjoyed, having Dr. White on the show today. And we've talked about a plethora of things, but all very, very important. Before we took that short break, the first question that I posed to Dr. White was this, to talk about what kind of work or works that she may be involved in to improve patient safety outcomes for the indigenous population of women, or BIPOC, as we refer to. So thoughts on that, Dr. White?
Yeah, I think, my first role is my everyday work. And no matter who it is, making sure that I'm also providing the best quality care and providing the resources that I can for all our patients. The other is making sure that those around me, that we're also on the same page and making sure that we are serving our community. Some of the other work that I've done or I continue to do, I serve on a medical advisory board for an organization that addresses the health disparities and the inequities surrounding breast cancer and Black women, and making sure that we not only provide the support for women at the time of their diagnosis, but making sure that they are getting the care and the follow-up and the resources that they need. And that's more so in making sure that though this disparity has existed, it stems within the inequities that play a role within our healthcare system. And that is understanding our community, recognizing that there are areas at which are de-invested in and lack of resources. And so, we all as medical providers play a part in ensuring that we're doing the best making sure that we're providing the quality care in every situation to every patient, and continuing to follow up with them and not lose them to follow up. And the other is building a pipeline also. We don't have a huge representation. What I had started early on was saying, I represent less than 1% of the Black women surgeons that exist here in the United States. Mm-hmm. And so there's a lack of pipeline that exists for really nurturing a lot of our students in school, high school, college, who want to go into medicine, but may not know what route to take, or the student loan issue, or financial aid, or they have the responsibility of taking care of family or loved ones and may not really know how to navigate their dreams versus taking care of their family. So a lot of what I also do is mentorship, and I make sure that I'm engaged in organizations that are creating pipelines for getting more Black and brown physicians within the system.
Yeah. Oh, wow. I think that's awesome. You talked about a little bit, within the healthcare system. So just that continuity of care for our patients and all of the things that you just described, it's always, to me, I think that your patients reflect or relate better to someone that reflects their ethnicity, who understands where they come from. And that shift has got to change. We've just got to get more Black and brown men and women into the healthcare system. And I'm just going to say, look, you're going to die on somebody. So get the school loans and keep it moving for sure. But we had a quick question that came up, Dr. White, and it was, do you have to report STD cases? That's a good question. And if so, to who?
Yeah, usually to the public health department. So certain cases, HIV, syphilis, gonorrhea, chlamydia, particularly STDs that can involve community, right? Easily spreadable through sexual contact. And so typically here at Alameda County, through our Alameda County Health Department, they do receive our CMR, what's called CMR, can't remember exactly, some report that gets sent over, and where they can look at where there are outbreaks. Now, what they do with that information at this point, that is much to be said. But I think for us on a day-to-day basis, for me in particular in my practice, there's so much education that gets involved with having these discussions about what it means to now be diagnosed with gonorrhea, chlamydia, or now diagnosed with HIV, and how to protect not only themselves but also others, and that's actually probably the best part that I find truly necessary in this work is making sure that we're continuing to also educate each time we're in contact with patients, and making sure that, okay, you know what, I'm gonna see you in 2 weeks, and we're gonna see how you're doing, and we're gonna make sure that you finish your medicine. We're gonna make sure that you're not having any more symptoms, and then we'll go from there. And I think that really keeps patients not only on their toes, but they know, like, wow, you know, I have a provider that's looking out for my well-being. But
totally engaged. You know,
totally engaged.
And I think that that's important. Dr. White, here's my last question for you. Time
Yes,
has
ma'am.
gone by.
It has.
What do you want people watching this show to take away from today's discussion?
Yeah. Know that you are your best advocate, and that though you recognize that medicine always presents as standards and follows by the book, but each individual is very unique. Make sure you let it be known, and don't hold back. I know that I appreciate so many times when I have mothers that come in with their 5 kids. But what makes me so happy is that they were like, look, I'm going to get here. Even if I have to bring all 5 of my kids, I'm not missing this doctor's appointment. And so I recognize, and I think so many of my colleagues that I work with recognize that our community members, our patients, they want to be healthy. They want to make sure that they are taken care of, and that that their providers have the best interest. But I also encourage every single one of you to know that you are your best advocate. Don't get overwhelmed with the medical terminology. Remember just to ask those generic questions. What is it? Why am I having it? What are we going to do about it? When are you going to see me again? You know, how do I make it better? And know that, you know, there are providers out here who are doing the work, and they want to see their community thrive. And that's where I stand.
Yeah. And also providers that care, because that's what's coming through loud and clear is the care. So Dr. White, don't you go anywhere. I'm going to be right back with you. I want to say to all of you guys, thank you so much for tuning in. And I want to really thank Dr. Kasandra White for being on the show today. It is my hope that you found the information that's shared to be educational and informational. Hey, I want to remind you guys to be sure and follow me on all of my social media platforms. Be sure and follow, like, and share. And also log in, you guys, every Tuesday, 5 p.m. Mark your calendars for always a great show. If you didn't get the memo show, I guarantee you will not be disappointed. Also, just a reminder, I still keep getting feedback. If you missed an episode, you can actually go back and watch the episode. It's up. It stays up on YouTube. It stays up on LinkedIn. Just look for Gloria Bailey Ray on Facebook and LinkedIn, and on YouTube, look for the You Didn't Get the Memo show, okay? But we've had a great discussion talking about understanding the gynecological healthcare needs for women of color. And in this short amount of time, there's a lot of things that has been shared. But guys, I pray that you've taken something away from today that will help you and will help your family members. As I always say, if you didn't take anything away from today's show, then it's really you who didn't get the memo. Remember that the quality of your life literally is determined by the decisions that you made. So be sure and give thanks, pay it forward, and just know that I'll see you this time next week. Until then, I'm your host, Gloria Bailey Ray, and you have been watching the You Didn't Get the Memo show. Thank you guys for being here.